Hello everyone, my name is Vincent from the University of Leeds, and thank you very much for the Royal College of Radiologists for awarding me this 2020 Stephen Carstairs Research Prize for my project on comparing image-guided ablation and partial nephrectomy for small renal masses. Managing small renal cell carcinomas with partial nephrectomy can be problematic. Firstly, it is technically demanding and limited to certain anatomical locations of the tumour. Secondly, it is associated with complications and drop in renal function. This has led us to think if there are better ways of managing small renal masses. Will interventional oncology be a solution? This slide shows 3 CT images of patient undergoing image-guided radiofrequency of a small renal mass. Essentially, a needle is inserted into the kidney under image guidance. The needle produces radiofrequency or other energy sources in an attempt to destroy cancer cells in the kidney. The first percutaneous image-guided RFA was performed in 1998. Since then, other energy sources such as cryoablation, which the use of an isotope to destroy the cancer cells, microwave, and irreversible electroporation has been used. Image-guided ablation avoids major surgery such as laparoscopy and robotic surgery, which is correlated with less complications and better renal function preservation. Currently, the European Association of Urology guidelines only recommend image-guided ablation for those who are not fit for surgery. It was also suggested, based on low-quality evidence, that ablation is associated with significantly higher recurrence rates. Our systematic review previously suggested the lack of long-term studies in the area, and there is limited evidence directly comparing image-guided ablation and partial nephrectomy. Prospectively randomized evidence is proved to be difficult from the SURAB and CONSERVE study. This is the first study to report 10 years outcome of cryoablation or RFA versus partial nephrectomy and will potentially be guideline changing. This is a single-center retrospective study of a prospectively maintained database. Patients with T1A or T1B non-metastatic local RCC undergoing image-guided ablation or laparoscopic partial nephrectomy were included in the study. Patients were followed up at 1, 3, and 6 months before commencing on annual follow-up. A total of 296 patients were included. Of those, 258 have T1A disease and 58 have T1B disease. In both T1A and T1B cohort, patients undergoing ablation are significantly older, as shown in the graph here, have larger tumours, more complex tumours, more comorbidities, and worse EGFR. Cancer-specific survival was found to be similar in T1A patients undergoing ablation and partial nephrectomy, as evident by the 10 years cancer-specific survival rate. Similarly, the Cox proportional hazard regression model have concluded the same. Similarly, no significant differences were seen between cryoablation, RFA, and partial nephrectomy in overall survival, local recurrence-free survival, and metastasis-free survival. Similarly, in T1B patients, the oncological outcomes are comparable among the 3 groups. Initially, propensity score matching analysis was planned, but this has been proven impossible because of the extreme baseline characteristic differences in the 2 groups. Therefore, multivariate Cox regression was used to take account into age, sex, tumor laterality, Charlton Comorbidity Index, renal nephrometry score, lesion size, histological type of RCC, grade, and T-stage. After taking account into baseline characteristics, in T1A patients, local recurrence-free survival and metastases-free survival is significantly better in patients undergoing RFA compared to partial nephrectomy. In T1A and T1B patients combined, local recurrence-free survival is significantly better in patients undergoing cryoablation and RFA compared to partial nephrectomy. Although these results have been shown significantly different, interpretation must be cautious due to the small sample size and small number of events. The complication rates and severity is comparable amongst cryoablation, RFA, and partial nephrectomy in both T1A and T1B patients. Change in renal function is significantly smaller in those undergoing ablation compared to partial nephrectomy in both T1A and T1B patients. It is worth noting, in those undergoing ablation, the interquartile range spans 0, suggesting potentially no change in EGFR in many patients. Upon linear regression, we found in T1A patients, those undergoing cryoablation and RFA have an 8% and 12% smaller drop in renal function respectively when compared to those undergoing partial nephrectomy. In T1B, those undergoing cryoablation and RFA have a 17% and 22% smaller drop in renal function respectively compared to those undergoing partial nephrectomy. Finally, although we found ablation to be superior compared to partial nephrectomy in certain oncological outcomes, based on limited number of events, our study could only cautiously suggest cryoablation or RFA to be at least as good as partial nephrectomy. However, we found ablation to be associated with significantly better renal function preservation due to better conservation of the renal parenchyma. Interestingly, other studies have found patients undergoing ablation to be older and more frail, hence contributing to the poorer overall survival. However, we found overall survival to be similar in the three groups. This might be because of the longer life expectancy and better healthcare in the UK. Furthermore, our very long-term follow-up may have compensated for the old age of ablation patients. We did not find differences in number or severity of complications in the three groups, as ablation also comes with its own complications. Complications arising from general anesthesia are also applicable to all three groups. This study is the first to report 10 years outcome comparing image-guided cryoablation, RFA, and partial nephrectomy. We have shown that ablation is at least as good as partial nephrectomy for oncological outcomes and better renal function preservation. Hence, ablation should be offered as first-line treatment alongside partial nephrectomy to patients with small renal masses. Finally, I would like to thank Professor Zimin Hua for valuable guidance in making this project a success. Thank you very much for listening.